Thank you for joining us for a Collegial Conversation with Diana Clark. Joining us today is Ray Santamaria. Ray is a licensed marriage and family therapist and the executive director and founder of One-to-One Treatment, an intensive outpatient program for mental health and dual diagnosis located in West Los Angeles. He has previously worked in residential treatment centers as a clinical director, treatment coordinator, and a primary therapist. His areas of expertise include trauma, intimacy, addiction, and dual diagnosis. Ray is joining us today to discuss the difference between therapy and treatment and building resilience in clients. Thank you for joining us, Ray. I will now pass the conversation over to Diana.
Thank you, Laura, and welcome, Ray. It is so
Hi.
nice to see you on this collegial conversation.
Yes, thank you for having me.
You're welcome. We've had many quote unquote collegial conversations over the years, but this is exciting for me to hear what you have to say so that we can tape it, because I have learned enormous amounts from talking to you. So
thank you.
That said, let's talk about, you run an outpatient program that mirrors, or not maybe mirrors, but seeks to provide full treatment to individuals outside of a bricks and mortar structure, correct?
Mm-hmm. Yeah, that's one piece of it. Yeah, so one-to-one treatment is an intensive outpatient program. And how we're different than most outpatient programs is we don't offer groups. We're big believers in group. It's a great modality. But in my experience working in treatment since the beginning of my career when I was training, what I noticed is not every client and their symptomology, their issues are ready for group. And sometimes they might even be in long-term treatment, group treatment, and then need more aftercare and they're ready to go deeper. And sometimes in treatment, if you stay in a group system for a long time, new people come in and then you might be in a different place than some of the new people. So what we do is, that old cliche is meeting the client where they're at, is we provide the treatment directly to them on a one-on-one basis without groups. And with COVID having happened and still happening, a big component has been telehealth. So we are able to treat people statewide in California via telehealth if this is an appropriate level of care for them. And then for people who are local in West Los Angeles, we do have an office for in-person. So we really started in person, but COVID really opened up the world, right, to telehealth. And I had never considered doing that before. And it's actually been pretty effective.
It is pretty effective. It has its limitations, just like anything else.
Yeah.
But back to what is the difference then? If you're treating people one-to-one, what is the difference between treatment and therapy? What's the nuance?
Gotcha. Well, so in some respects, what we do one-on-one is really the same thing that you would do in a group. We are bringing specific evidence-based modalities, whatever they might be, cognitive behavioral therapy, DBT, acceptance and commitment therapy, whatever it might be, that would be done in a group, providing some psychoeducation, skill building, and process. We are doing that just one-on-one. So, but for both of those scenarios, there's that component of they are participating in a treatment modality. So in a group, you're doing therapy.
Correct.
Therapy modality, I meant. In a group, you are doing therapy. An individual, you are also doing therapy. But what's different from the frame that we offer, or any intensive treatment program or residential treatment program, is the difference between treatment and therapy. And what I mean by that is, when we go to school, and you might remember this too, they don't teach you how to be a therapist in treatment. They teach you how to be a therapist. And a lot of it is based in that sort of old school psychodynamic theory, which is great and really the foundation for so much that's come after. And they teach us how to be in the room one-on-one with someone. The difference between that and treatment is a much bigger umbrella. Therapy is a part of it. And also I want to say, when I say treatment, I'm talking about treatment facilities, programs for people that actually need to go because individual therapy is not enough. They may need more stability, whatever it might be, for mental health, mood disorders, trauma, addiction, of course, a big one. So treatment is that bigger umbrella where the therapy happens within, but it's a much different frame. It's not a frame of you come for 45 to 50 minutes, we do our thing, and then you go off. There's a lot more boundaries and structure and collaboration that happen within treatment. And most master's program and even doctorate programs, in my experience, don't actually offer that extra experience or education. And usually we find that out by being trained or working in a treatment environment. And we learn the hard way, which is actually great. We become seasoned therapists within treatment. And we learn things that were a little different in school. You know, for instance, in a treatment environment, one of the classic sort of psychodynamic things is leaving space and not working harder than the client and holding space. In a private practice with someone who's pretty functional, stable, not suffering with intense symptomology, that can be very necessary. In a treatment environment, that can be very necessary too, but we're also dealing with people that have much more activated nervous systems. They might be coming out of acuity or crises, and so they might need more wrapping around. And so it may not be the best intervention for some therapy sessions to just sit there and be silent the whole time.
Right, I can imagine that would induce more paranoia and more sense of aloneness
Mm-hmm.
than connection we're seeking, right?
Exactly. And also even topics like self-disclosure, we have to consider them differently. Self-disclosure from a therapist. In a private practice, you know, some people self-disclose a little bit. Some people might lean a little more traditional and be a blank slate. So someone in a private practice might ask, yeah, I'm here for alcoholism. Are you in recovery? In a private practice, you might say yes, or you might actually go, well, what does that mean to you? And really talk about that. In treatment, every therapist has to, you know, look at it differently. But in treatment, that might mean something completely different to the person. This might be their first experience. They're pulled out of their life. They just got out of detox. They're in a 30 to 60-day rehab. And their first connection with someone might be that question, are you in recovery?
Right. And will you
And
judge me? Will you judge me? Because what I'm
exactly.
experiencing right now is enormous shame for having to be here in the first place. Do you
Ex-
get where I get? Yeah.
Exactly. And that's a great point. The shame, something that I've come to understand is, you know, so many of us, when we go to therapy, we bring all that critical self, the shame and all of that. It's much more heightened when we're in that intensive environment because something's happened beforehand that got us there.
Right.
You know,
Right.
we've done something or something's happened, or, you know, we've been impaired or sufferers of trauma or whatever the event might be that we're coming out of that required that stabilization. So many times we're going to, you know, be embarrassed, filled with shame. And that's another piece that I think is a little different is in a treatment facility, we have to be very conscious of that when people are walking in and do our best to wrap people around with that. Whereas in a private practice setting, that might be something I have back here, but that person may not be experiencing intense symptomology. It may be more relational stuff, work. They're still healing from some childhood trauma, but it doesn't have that event that may have contributed to more intense treatment experience.
So I would imagine that throughout your tenure in this field, you have seen amazing examples of resilience and change in people, because one of the beautiful things about working in a setting where we're treating people with substance use disorders is they do change. We see tremendous growth in what many would say in a pretty short period of time. Once the neurochemicals start to stabilize after 30 days, then we can start talking about insight, and then we can start really working through things because they feel motivated in that moment. Tell me, what, give me a good story of resilience. I'm feeling the need for one.
Well, the one that comes to mind right now is actually a very common one that's happened with clients, whether it be in my private practice, to be honest, or a lot of times in treatment. A lot of our clients that we've seen, in treatment facilities, whether it's been residential or intensive outpatient, is they may not have certain skills in the moment. And especially in the addiction world, there's so many different theories and all that. And some of the more traditional, even 12-step sort of theories, which are wonderful and can help people, they don't always fit for everyone. And sometimes, that could really, people may not feel connected to it and then feel like it doesn't work for them or something's wrong with them. So one of the things that I think is really important is, at least for our clients, is I want them to understand that we're human organisms. And like any organism, that lives on this planet, our goal is life, survival. So anything we do or don't do, whether it's adaptive or maladaptive, is an attempt at survival. So even that, when you walk in and realize that your intravenous, heroin use is an attempt at survival, that can really shift something. And then people can start looking at themselves rather than what's wrong with me, what's happened to me, how can I move towards the life I want? So all of that to say that that's kind of where I want to start with people, but then also start to reframe some of the old thinking that people have. We can be very black and white when we're new to any type of recovery or treatment, or haven't had that emotional intelligence, developed in us. And so it can be very all or nothing thinking. And we want to point that out to people. And that could mean if I'm having some feelings that day, then this is not working. And so one of the stories, it's actually many stories, so I'll kind of bring it all together in one example, is like medication, where people have been in treatment and they're like, the meds aren't working. And I'm like, okay, let me hear what you're saying. And they're talking about having some feelings. But then what I might do is say, I'm not saying they're not, and you have to talk to the doctor about that. I'm not a doctor. I do want to throw out though, what if they are working? Because before you got here and when you got here, you were having panic attacks, you couldn't sleep, and you were ruining your life. You were pushing everyone away. So right now, you're here, you're stabilized, you voluntarily extended for another 30 days, you're not having panic attacks, you're reconnecting to your family, your children, your spouse, whatever. You're sitting through your groups, and you happen to be having some feelings. And then that's where I bring in, we call that resilience. Resilience doesn't mean you're feeling great.
No.
Resilience doesn't mean everything's working.
Right.
As we know from trauma theories like the trauma resiliency model or somatic experiencing, they have what they call the resilience zone or the window of tolerance. And it's that zone. And oftentimes clients come into, treatment and their zone's that big. So the stressors and the ebb and flow of their life and their humanity, to be honest, is in this small little range. So it can go out of it, the intense highs. It can go below to the intense lows. It can be extreme activation. It could be extreme shutdown.
Yeah.
So we want to do is spread that, and life happens bigger and bigger. So then I feel good today. Oh, I feel bad. Oh, I feel good. I feel bad. But it all happens in this window of tolerance, or also known as the resilience zone. That's a big thing I think that clients everywhere need to know about, because then they can have a different perspective. And it's very Zen-like, in fact. We can't have, or even Confucius-like, we can't have a sorrow or joy without some sorrow. We have to be able to feel the wide range and tolerate it.
And our
And so,
brains, what I love about this is our brains are built for having both. We aren't built
exactly.
as joy machines, and we aren't built as misery machines. We seek balance all the time.
Exactly. So in that example, I remember, several clients that it really clicked for them. They look back and they go, wow, you're right. I am actually tolerating not wanting to be here. I'm tolerating the shame of the wreckage that I left before I got here. I'm tolerating my anxiety and terror. I'm not hiding it. I'm not running from it. I'm not pretending it's not there. But I happen to be in a zone of resilience, which is allowing me to participate fully in treatment.
And have the full range of feelings, right?
Exactly. And sometimes they can be very conflicting, contradictory even. we can be experiencing extreme joy and grief at the same time. And in fact, it's been my experience personally and professionally, the more we grow and expand this resilient zone, that happens. For instance, I think of my kids and I can have so much love and joy and gratitude. And then right there is grief because they're growing up,
Well, and we also are so fragile with our children. We know if something happens to a child, that life as we know it will not be the same.
Exactly.
And so we are fragile when we love, and it is always mixed a little bit with grief because
Exactly. Because it's temporary.
right.
Everything's temporary.
I know. So I have a question. Let's imagine you're working with somebody and you do a really good job of framing resilience and hope and all of this. How do we hold up a mirror to somebody about behavior that they don't want to see? How, when we're dealing in treatment, there is a whole lot. What the group process I always imagine brings is that mirror of recognition, like I did that too, without having to generate that moment. How do you navigate that in the confines of one-to-one?
Yeah, that's a really great question. So yes, group can be very, very powerful and helpful for that within the right dynamics of the group. And that's also just a quick note why we this is just another sort of soapbox of mine. Why we exist is group is amazing. I've run probably 1,000+ hours of group, and when it works and you have great dynamics and great participation, it's magical. And then sometimes when the dynamic is dysfunctional and there's some disruption, it can be very difficult. And for some of our clients, it's asking almost the impossible. We're going to take you off the street. I'm just going to use an extreme example. You're shooting up, living on the street. We're going to take you out, clean you up, and put you in this group environment, and you need to behave. And then when they don't behave within the confines of the structure, some of these old sort of, concepts we have, resistant to treatment. If we go into 12-step stuff.
Denial.
Yeah, exactly. Denial. You're not ready. You're not surrendered. And clients wouldn't need us if they can do that just by picking them up, giving them a shower, and dropping them somewhere. So, to that end, we are very clear that if someone does need group, they should be in a group setting. Okay. So a lot of times when people come to us, they might come to us after a group and we'll take things deeper and they've had that experience. If someone hasn't had a group experience when they're with us, we are very, very mindful of an outside community experience. What we don't want to do is collude and enable a diagnosis like depression. So for instance, for some people with depression, our model sounds great. I don't have to see anyone. I don't have to talk to anyone, especially with COVID. I don't even have to really get out of bed. And so that might not be a person that's a fit for us because we're very mindful of the social piece, that social engagement piece. We are social animals. We need that loving connection. Babies are born needing that connection, that attention, that holding, and that stays with us. We need that. So we're very mindful of that. So to that end, we are going to be supporting some sort of outside community, whether it be a 12-step community, if it's a fit for them, a religious community, spiritual, yogic. I remember, I had clients that it was CrossFit, their CrossFit community. And all, runs the gamut of different ways they can get that community connection. And then how we can also mirror in real time in the confines of the one-on-one relationship in our model is we do reflect to them humanity, in terms of, yeah, that's normal. We normalize it. And that's what we have different, therapeutic modalities for. Something like acceptance and commitment therapy is really, really important. What I really like about that is the values piece, which can be very cognitive behavioral therapy like, but it doesn't really imply any sort of thinking error. So for instance, we can reflect and mirror someone by saying something like, is that behavior moving you toward or away from your values? So we have quite a few modalities and attachment, therapy interventions that normalize the human experience. So we will definitely do that in a one-on-one environment, and we're very cognizant of that because we know we don't have the community to do that. So we are doing that on the one-on-one with certain modalities, but always keep it in mind that whoever's with us is always going to need some sort of social connection. And a lot of times they might be in transitional living, for people suffering from addiction, a sober living. So they are getting some sort of community.
Got it. Got it.
Yeah.
That oxytocin elevated by connecting. We are social animals. Yeah.
Exactly. And that's also a big piece of why I know our model works. And again, not for everyone, groups not for everyone, in my opinion, and one-on-one isn't for anyone. We're just one more thing on the continuum of care. But for most of our clients, that oxytocin, that attachment connection, it develops quicker, and we can foster it in a more efficient way because it's one-on-one. Again, group is great, but also the person's going to have to walk into group and either regulate themselves or ask for regulation to really understand what's happening. Take social anxiety as an example. That's going to be really hard to enter group, and then by the implied or spoken rules of share, be honest, that's going to be almost impossible for someone with significant anxiety. And also the same thing with significant trauma. To walk into a group, and it's very hard to share what happened to you when you're barely facing it for the first time yourself.
I like it. I like it. So we have a few more minutes, Ray, before our half an hour is up. What would you like to leave our listeners with today?
Well, going back to the bigger theme of therapy versus treatment is, therapy, that sort of talk and the work that we do, whatever modality it might be, that's inherent in the treatment structure. But treatment is so much bigger. It requires things like boundaries, limits, collaboration. Therapy is just one piece of that. And sometimes clients don't understand. They just think, I'll go to therapy to get better. But sometimes we need that extra containment, that stability, that real-time, that real-time feedback too.
Yeah.
That real-time feedback and hand-holding. And so I think, what I'd like to leave the viewer, listener with is to really take that into consideration when you're thinking in terms of treatment facilities. Does my loved one, does my child, do I need an intensive level of treatment, either at the outpatient level or at the residential level? Yes, you will get skills, psychoeducation, and therapy. You can get those things in a private practice too. But do you need that extra stuff that you're not able to provide for yourself? And I think that's what the treatment structure does. Discipline, consistency, structure, love, mirroring, reflection.
Yeah.
Accountability. Yeah. And as new therapists, we kind of learn that from being thrown in. Because I remember when I came in and I was just the best. I got to tell you, I was the best academic student therapist in my first treatment center. And that didn't work. That didn't work.
Make a bit of difference, does it? I know.
I couldn't hold limits. I couldn't hold boundaries. My countertransference. I would, get lost in, I believe the client. I don't think it was their needle, and you get seasoned over time to kind of start to understand and see the bigger picture and the nuances and that extra education that you don't get in school until you're dealing with it. You take all the same concepts, but it looks different. And so, for instance, when I was clinical director of a treatment center, part of the therapy, part of the experience was me riding in the back of the ambulance, when someone cut themselves to the hospital, when someone wouldn't go to group and they were pushing back and pushing back. And I said, you know what, I'm just going to sit here then. You don't have to go to group and we don't have to talk, but I'm going to sit here for the hour that you're supposed to be in group and just be with you. Yeah. Structure, the frame, discipline, connection.
Connection being key. Because
Mhm. And that's the thing about treatment is there's different ways of connecting. It's not just you're here for 45 minutes in the session, bye. It happens with the text. It happens with the chef. It happens in real time.
That's right.
Everything we do or don't do in a treatment facility is potentially therapeutic.
Thank you. Thank you, Ray. That was wonderful discussion. I love the conversation, particularly about resilience and the idea that we can view somebody as broken or as a resilient human being and help them see the resilience in themselves. Thank you.
Exactly. Oh, thank you so much. I appreciate it. That was fun.